Next, I invite Dr. RAJANI NAIR, Assistant Professor of Ophthalmology, KMCT Medical College, for her talk on the diagnostic challenges and approach to ocular tuberculosis.
Good morning, everyone. So I'll begin with what are our challenges. So to begin with, the gold standard of TBU is the detection of Mycobacterium tuberculosis in ocular tissues or fluids. Demonstration of this bacillus by smear or culture from ocular samples is seldom achieved because of the low tissue load and obviously small size of ocular tissues biopsy samples. And ocular TB can involve any part of the eye and can occur with or without evidence of pulmonary or extrapulmonary TB disease. In this scenario, diagnosis of ocular TB is in most cases presumptive, and therefore we rely heavily on the characteristic features and ancillary investigations. So, namely the TSTs, IGRAs, and chest X-rays, chest imaging. So, a quick refresher on the tuberculin skin test. It is done by intradermal injections of a purified protein derivative, which is a mix of antigens, which may include specific to Mycobacterium tuberculosis and non-specific forms of MTB and BCG. Therefore, there are chances of a false positive, especially in those vaccinated after infancy or twice in their lifetime. The reading again, criteria for positive TST again depends on the immune status of the patient, with lower cutoffs having to be taken for immunocompromised individuals. ESAT6 and CFP10. Emerging evidence suggests that these tests may offer similar specificity to IGRA, and when compared with MANTO, they may provide more reliable results in children and in people living with HIV. CYTB is one of these tests. It's developed by the Serum Institute of India, and it uses a 1:1 ratio of two recombinant proteins, the ESAT6 and CPF10. And it is administered by the same intradermal method, but the induration is of greater than 5 millimeter is considered positive regardless of the immune status of the patient. There is also a similar test produced in Russia, Diagnostic test, and here any presence of any induration or papule is considered positive, and it's just graded into poorly expressed, moderately or pronounced response. There is a similar CTST. This is also second generation tuberculin skin test that's produced from China. Now coming to the IGRAs. What are the IGRAs? IGRAs are in vitro method aimed at measuring interferon gamma release to antigens of MTB. These again IGRAs are based on the lymphocyte response to the two specific antigens, and the results are not affected by prior BCG vaccination, making these tests more specific than the traditional tuberculin skin tests. The IGRAs are available as two different tests, the quantiferon and the T-spot test. Quantiferon TB Gold Plus is the newest generation of quantiferon tests, and it is an assay which is done on a whole blood using peptides that simulate ESAT6 and CFP10. This assay has 4 tubes. One tube contains the mitogen and acts as the positive control. Another one contains nothing and it's the negative control. The third tube contains the TB specific antigen. And the fourth tube has the same antigen mix, but the peptide lengths differ to elicit cell-mediated immune response both from the CD4 and CD8. The fourth tube was developed with the aim to improve the detection of latent TB infection among recently exposed contacts, immunocompromised hosts, and young children. Report is then quantified as interferon gamma in international units per millimeter. The cutoff is provided by the manufacturer. T-spot TB assay is an ELISpot assay where again the antigens are incubated with peripheral blood mononuclear cells. The T-spot test requires a additional normalization step, which the peripheral blood mononuclear cells are isolated, washed and counted to ensure reproducibility. The tests are then, the test has 4 wells to which this isolated PBMCs are placed, and one well will contain nil, the other will positive control contains phytohemagglutinin, and 2 of the M. tuberculosis specific proteins. So reaction within those two wells gives you a positive result. So in short, what is the difference between an IGRA and TST? The advantages are it requires only one visit. There is no cross reaction with BCG, and a limited time frame from draw to incubation. TST requires 2 visits, and it also changes because there is a subjective determination of results in TST. However, IGRA is exempt of that. But they both share the same disadvantage that they cannot differentiate between latent and active TB. Chest X-ray is the other modality that we use. There are no radiological features which are themselves diagnosis of primary TB, but the presence of consolidations, hilar enlargement due to lymphadenopathy, typical features of primary TB. In chest imaging, HRCT is preferred to X-rays where possible because of the higher sensitivity in detecting lesions. Now coming to the management, the COTS group is an international expert-led group that came up with the consensus guidelines to guide the initiation of ATT in patients with tubercular uveitis. An endemic country was defined as that which had more 100 cases per 1 lakh person, and again the tests used were TST, the IGRA, and chest X-ray or computed tomography. COTS experts concluded therapeutic decision is marked in making is influenced by the specific phenotypes and the endemicity of the patient. The report 1 dealt with the tubercular serpiginous-like choroiditis, multifocal choroiditis, and tuberculoma. So coming to the tubercular serpiginous-like choroiditis, it is a phenotype which has a strong predictive value for ocular TB. And in an endemic region, an isolated tuberculin skin test of greater than 10 millimeters was sufficient to initiate ATT. Tuberculomas are also another phenotype which is highly representative, and commencing ATT should be considered if one immunological test with positive results and no radiological finding, or just a positive chest radiography alone was sufficient to start ATT. Focal or multifocal choroiditis, however, have relatively weak association. The use of ATT must be supported by one immunological and radiological sign suggestive of old, healed, or active pulmonary TB for patients from regardless of endemicity. Now, the second report has dealt with tubercular anterior uveitis, intermediate, and pan and retinal vasculitis. So, tubercular anterior uveitis, the clinical phenotype of recurrent anterior granulomatous uveitis, whenever one of the immunological tests, either PPD or IGRA, along with chest X-ray, it is advised to initiate ATT. However, in the first episode of ATT, all 3 tests should be positive to start ATT. In tubercular intermediate and pan uveitis, when all 3 tests are positive, there is a absolute consensus in both endemic and non-endemic areas to start ATT. However, in endemic regions, either one of the tests and along with the positive chest X-ray or CT findings is enough to start tubercular treatment. Retinal vasculitis, 2 scenarios, either active or inactive retinal vasculitis. So PPD, IGRA, and chest X-ray are positive, you have absolute consensus, or if one of the 2 immunological tests are positive with a chest imaging. In an active retinal vasculitis, there was only a weak consensus to start ATT despite positive immunological and radiological findings. So what are the summary? In general, all patients suspected of ocular TB should be managed jointly by the ophthalmic specialists and the TB centers. So in the ophthalmic clinic, when a patient with uveitis comes with a positive IGRA, the tests that has to be done include urea and electrolytes, a liver function test, full body counts, chest X-ray, and syphilis serology, also screening for HIV, hepatitis B and C, and sputum samples. If there is a history of coughing, sputum samples for acid-fast bacillite and gene expert has to be sent. Then tests should be, according to the ocular phenotypes or systematic inquiry and clinical findings elsewhere, should include HLA, serum ACA, C-reactive proteins, ANCA and ANA, toxoplasma serology, all depending on the phenotype that we have and other clinical findings. Imaging should ideally have color fundus images are recommended for documentation and monitoring, preferably wide field with autofluorescence images where available. Macular OCT, standard practice for evaluating macular lesions and macular edema. Wide field angiography is recommended where retinal vasculitis is suspected or to further characterize the chorioretinitis. The respiratory TB clinic should be have an urgent chest X-ray and consider CT thorax with contrast to guide sampling to sample induced sputum bronchoscopy or endobronchial ultrasounds in patients with suspected OTB. So to conclude, the TST and IGRAs are useful immunological tools in identifying individuals with prior TB infection and are an additional and useful tool in a composite approach to diagnosing presumed OTB. IGRAs may be associated with false negative and active TB and should not be used as a sole tool to rule out OTB. A combination of both IGRAs and skin tests may offer the best sensitivity. And the COTSCON calculator, the online calculator that is available, I think will be discussed next in the management. Thank you.
Thank you, madam. That was a very enlightening speech on the diagnostic challenges